Thank you, Dr. Sabu, and my good friend, Dr. Anuj Maheshwari. At the onset, I would like to thank Dr. Bansi Sabu, Dr. Jyoti Dev Kesav Dev, Dr. Amit Gupta, Dr. Rakesh Parekh, and the entire team of Digitonians, as I call them, for having Dr. Asgaonkar recognized, Senior Dr. Asgaonkar. And we all know Dr. Senior Asgaonkar was one of the first persons to found the Diabetes Association of India, which is one of the largest associations of diabetes worldwide, because it has people living with diabetes, which is very important. And I'm very happy that Dr. Sabu's team has included people living with diabetes in this meeting, because technology is there and human touch is very important. So in this era of artificial intelligence or machine learning and digital diabetes care, we need to do it with human touch. My only duality and conflict of interest of this talk is Dr. Bansi Sabu. So we need to embrace digital diabetes care, and we need to have a bright future with that. And that's how people will talk. And the last 2 years of the COVID pandemic allowed us, in fact, it is that SARS-CoV-2 virus which allowed us to digitalize and penetrate worldwide in a global village in a digital fashion. In fact, as we talk today, we are able to talk virtually, and we are able to use technology in a more efficient way. So in the next 25-30 minutes allocated to me, I'm going to talk of a concept already talked yesterday called the Digitosome. And in the digital diabetes space, how can we integrate technology in a much better way to improve patient care? Then, of course, I will talk a little bit about remission and the twin way to reverse diabetes, because through Dr. Sabu, I was introduced to this whole twin team, where Twin Health, we are trying to generate some high quality science, which we are presenting at the AD itself. And then some areas of artificial intelligence in diabetes, of reversing chronic disease. It's not just diabetes which we can reverse, but I think probably using technology, we can reverse a lot of diseases. Yesterday in a discussion, some people were saying that technology is responsible for sedentarism, but technology is also responsible for activity. So maybe a couple of take-home messages. So clearly we know that artificial intelligence, autonomous vehicles, big data analytics and cloud computing, customization in 3D technology and 4D technology, Internet of Things, and robots, drones, social media and platforms are the order of the day. And Twin is no exception. One of the things which has happened in diabetes space is continuous monitoring. And we monitor health constantly. And in the life care space which we work in, we monitor it. We also have seen the explosion of retail clinics, where people are able to get convenient access to routine care and information in a synchronized digital ecosystem. So we are building an ecosystem now. We are looking at a connected home, whether it is me or whether it is Dr. Sabu or whether it is Bharat or Anuj. From our home, we are able to connect. I think Anuj must be probably in United States. We are able to access health information, and we can make decisions and actions based on the information we get in a connected home. And ultimately, we have to evolve intelligent treatments, which are customized and personalized, and based on machine learning, look at individual mapping and pattern recognition. So that's really the key. So the monitoring has allowed us to understand the patterns better. These patterns can be delivered and made available at home, and retail virtual clinics are allowing access to devices and drugs at home, and treatment options can also be delivered at home. So when you look at Digitosome, and this is a slide I have borrowed from Dr. Bansi Sabu, we are looking at 3 major areas. First area is diabetes prevention, in which we are looking at screening, targeting hard to reach population, personalized prevention, health literacy and e-coaching, lifestyle changes, and reactive public health interventions. That's really the ecosystem in the Digitosome. When you're looking at diabetes care, we are looking at biomarker monitoring, glycemic control, health system in economic models, patient empowerment. And when we are looking at diabetes research, we are looking right from pharmacovigilance to genomes to data interoperability. And then, of course, we have to synthesize big data and artificial intelligence, which is nothing but machine or deep learning, and NLP, which is natural language processing. And all this can only occur because we have wearables now. So we have a wearable Fitbit, we have smartphone apps, we have smart medical devices and sensors, we have social media connectivity, we have Internet of Things, we have telemedicine, we have smart drugs and smart e-health ecosystem health records. So that's really the Digitosome. But the main thing in diabetes space is one of the rate limiting step for treating in diabetes was hypoglycemia. And we know that the fear of hypoglycemia and its linkage with outcomes has been hugely discussed in the last 2 decades. And that has a huge direct and indirect cost to it. Whether it is admissions, physician visits, whether it is absence from work, work disability, accidents, clearly hypoglycemia has been a major rate limiting step. And that is the first space in diabetes where technology has got integrated. And the contributing factors for risk of hypoglycemia to be increased, whether it is young children with type 1 diabetes, which Bansi works on, whether it's pregnancy or renal impairment, whether it's glycemic variability or duration of diabetes or alcoholism or fast, or whether it's a geriatric population, people with heart or liver disease, or people with intensive control or history of severe hypoglycemia or impaired cognitive dysfunction or impaired awareness or exercise, all these are hypoglycemia prone situations in everyday life of a person living with diabetes. And this can be mitigated very beautifully by using technology. So when we are looking at mitigating hypoglycemia, of course, we can innovate insulins. We saw some innovations from the previous speaker. And clearly, we know that there are better and better availabilities. But we also have technological advancements. We have seen the advances in pumps, starting from 60s, which were a prototype pump, which was large, to a wearable pump, which was on the back sack, and to miniaturized devices, including patch pumps, which have evolved. And then the real change has happened because of glucose monitoring, whether they were in the body, like a Libre, or like the flash glucose monitoring. And of course, now we have Indian companies like Aries coming out with their own sensors, or the implantable devices, which can stay in the body for 90 days or 365 days. And this whole evolutionary journey of CGM has really been a game changer because we are able to recognize glucose better. And a couple of these sensors have been game changers. So ultimately, what we are trying to do is using raw data, pre-processing them, and ensuring that this is transformed into an algorithm. And once the ready data is synthesized and pushed through an algorithm, we develop a model. And based on a best fit model, the application is derived and a learning algorithm is developed. So the CGM sensors or the SMBGs or the electronic health records or including devices like activity apps, they are all the data synthesizers. And the models are all based by engineers who work on ANN, which is artificial neural networks, randomized forest plots, the particle swarm optimization, the support vector machines, the decision support tree systems, the natural language processing, and the pattern recognition. So that's really the predictive models which will be there. And I will illustrate an example of that in the twin health technology, which I'm closely involved with. And of course, we are also looking at smart insulins because we want to have insulins which are glucose responsive. And that's really, oral insulin is not really our target. Our target is to have a smart glucose responsive insulin, which will turn on and turn off when needed. And therefore, oral insulin research really has not met and cut the ice to the extent the way they have been able to develop a GLP-1 analog orally. But clearly, the smarter insulins will be the ones which will come through probably nanotechnology. Remission quickly got defined, but it all defined again through artificial intelligence. Synthesizing all the data related, this is a Prisma diagram. So when you are actually looking at research, this is an example. They looked at 8,966 titles and abstracts related to remission. Of that, they only included 178 studies. So when you're actually synthesizing internet information, see how it goes. And then they collated all the data and looked at glucose lowering therapies, looked at glycemic thresholds, looked at cross-sectionality, looked at longitudinality, and they developed something called as Sankey diagrams for getting into an evolution of definition of diabetes. So these look complex because we are doctors, we don't understand mathematics, but that is how a definition evolved. And ultimately then, based on all that synthesis of published literature, they were able to define partial remission and complete remission. And fundamentally, these were the plots or the Sankey diagrams which were used in the definition of remission, which eventually now various international bodies have endorsed, whether it's the Endocrine Society, or the ESD or the Diabetes UK or the ADA, all of them have endorsed a simple definition of remission, in which we look at remission as A1C less than 6.5 for spontaneously or following an intervention which persists for 3 months in absence of any glucose lowering pharmacotherapy. And you can also use a ECGM or EA1C as a yardstick. We need to perform the test before and after 3 months, and we need to look at the yearly record of remission is a standard of care definition. Obviously, it's all linked to nutrition and precision nutrition, and it's all linked to lifestyle changes and how it has been skewed. We know we are at the epicenter. We know we have an Indian phenotype. We have a thin fat Indian phenotype. It is sedentary and affluent, but it is all about sarcopenia. And obviously, because we are sarcopenic Indians, we clearly have too much of carbs and too much of fat and too little of protein. We understood one thing better, that today type 2 diabetes, particularly in its first decade, is very much remittable and reversible. That is something very recognizable. And Professor Roy Taylor from UK showed that if you eat too much, you have a positive caloric balance. We stimulate a fatty cycle in the liver, and we also stimulate through insulin resistance a fatty cycle in the pancreas. A fatty pancreas, fatty liver is a twin cycle which can make a difference. And the root cause of this metabolic inflexibility is actually in the mitochondria, where in the mitochondria, our mitochondria of our body decide the ability to switch a fuel between a nutritional context, whether it is appropriate or inappropriate, whether it is flexible or non-flexible. And clear data from Differenzo's group shows very clearly that when we look at muscle biopsies of mitochondria from obese and type 2 diabetic subjects, clearly you can see they are much blunted compared to the others. So if you do caloric restriction, physical activity, or pharmaceutical interventions, you can improve mitochondrial biogenesis, reduce oxidative stress, mitochondrial function, improve insulin sensitivity, normalize cardiometabolism, and that's how reversal occurs. So these are the pathobiological mechanisms. The earliest studies came in 1929, where the first data set came on VLCD in obesity. But obviously in 1972, a Metrocal diet was criticized, and sudden deaths were associated with VLCD because there were low quality proteins with insufficient micronutrients. And therefore it took almost in 1995 that Codex safety standards had to be introduced for these drastic weight loss diets. So obviously the Codex then introduced in 1995 said that if you eat a very low calorie diet or a low calorie diet, it has to have a definition, a caloric definition of 450 to 800 calories or 800 to 1200 kilocalories. And it must have optimal macro and micronutrients with at least 50 grams of protein. It should be replete of micronutrients, and it should have at least 7 grams of fat per day. Otherwise, you can get adverse outcomes. And this was the Codex standard which was felt in. But our surgeons were one step ahead of Professor Taylor's group, and they decided that you can do bariatric surgery and you can actually remit and reverse diabetes. So there is a surgical pathway to that. And Professor Taylor showed that if you do a drastic, severe caloric restriction, you can get identical results what you can get in bariatric surgery. And his data set was very clear that whatever insulin secretion and the first phase of insulin secretion which was lost, by 8 weeks with severe caloric restriction, you are able to reset that. So in the direct study, which was an open label cluster study, he published in primary care in type 2 diabetics below 6 years duration between 20 and 65 with obesity, mainly with a BMI of 25 to 45, not receiving insulin. One was able to reverse diabetes, and this was something which was very, very doable. And most people were able to, at least 50% of the population in the direct trial, after 1 year, were able to achieve diabetes remission. So it was a simple formula: meal replacement with low calorie diet, negative calorie balance established, a depletion of liver and pancreatic fat and reversal of diabetes, and restoration of gastric emptying, insulin, GLP-1, GIP, and CCK, all which was well-based studies. Who responded better? Shorter the duration of diabetes and younger patients responded better. So obviously this was the first evidence base to show that type 2 diabetes can be reversed. But can we use technology? And when I met these two gentlemen, Jahangir Mohammed, who was the person who made Jasper Technologies and partnered with Elon Musk to develop the Tesla artificial intelligence backbone in the Tesla car, he thought that he can apply it to health, and he founded with Maluk Mohammed, who is an engineer from IIT Chennai, where he's located in the research park, and they decided to, with Terry Spoon from MIT, to decide to put up a digital twin. Just like in Tesla, you have the car is able to artificially recognize everything. Can in human health, can we use Internet of Things and machine learning and reverse chronic diseases and have a healthy life? And can we create a digital twin? Can we look at a complex metabolic milieu and ensure that every human being, which is different, because food cooked in every Indian household is different. Each individual, whether it is me, Dr. Sabu or Anuj, we are very close friends, but still our metabolism is different. Our reaction to metabolism every day is different. Our ability for the metabolic response is different. So it's a disrupted metabolism. So can we use whole body digital twin technology as an intervention to reverse diabetes and generate evidence based on it? So what does it do? It is a learning system first. Remember, all the AI-based systems learn and pattern recognize state of metabolism and look at cause-effect relationship and then predict options. So they look at health signals, including happiness signals. Remember, no program can be successful if there is no happiness. So the health signal is integrated, happiness signal is integrated, quality of life and happiness quotient is looked at, and causal or treatment signals are also looked at. And they are all synthesized, and they look at precision nutrition, amount of sleep and quality of sleep, activity per member, medicines which are supervised by a medical expert like a diabetologist or endocrinologist, and a coach which handholds you. So remember that without human touch, just AI does not work. Just applying a sensor will allow you to recognize and act better, but you need that human element. And remember, health is not only about just getting better health, but it's also about happiness. So it's an integral matrix, and that was really what it is. Like Twin, there are many other programs like Livango and Verta, which have tried to reverse diabetes, but they have not generated structured evidence base. And you can see here that with the early results from the Twin program, we're able to reverse diabetes in 1/3 of cases and various other conditions. And I'm sure Dr. Maluk has described them yesterday, whether it's blood pressure, lipids, obesity, renal function, liver function, beta cell and insulin resistance or inflammation. Most of it can be reversed in a very structured way. But obviously, everything needs an RCT. There is an ongoing RCT in Bangalore led by Dr. Parmesh Samanna's team, and that is undergoing a 2-year RCT. First year RCT results in the oral paper we are presenting at the ADA this year on Friday, the 3rd of June at 4:30, and I would invite you to come for that. I'm not showing any data there. So what does this whole technology do? Well, fundamentally, digital twin predicts based on the CGM readings in the first 35 days and pattern recognizes every individual's pattern. And then once it is synthesized, we are able to make a prediction algorithm on digital twin. So even if you take away the CGM, you will be virtually able to create a CGM. So using the Libre patch initially, in the first 30-35 days, we are able to recognize how you are. What is your glucose up and down? If you have a paratha, or if Dr. Sabu gives me a sweet dish, or if Anuj gives me in Lucknow a pan, how the glucose will go up and down. If I go for a run in the morning with Vinit, how will it change? So obviously it is now recognizing it. It is also integrating, apart from health, the happiness quotient. Am I stressed out? Am I very, very stressed out? Or am I happy? All this is integrated and you can create a virtual CGM. This is undergoing a patent now. Similarly, you can map blood pressure. Once you map blood pressure over 30 days for a human being, you will be able to replicate how a virtual blood pressure will be seen. And again, in this integral matrix, each and every parameter is encountered, including mental health parameters, to create a virtual blood pressure record. The most important thing is precision nutrition, because food cooked in every individual is different. Suppose I, Anuj, Vansi, Bharat, and Vinit, all of us have a idli. Glucose response may be different. Somebody it may be green, somebody it may be yellow, somebody it may be red. So we need to recognize that, and then for some you might have to reduce the idli quantity and increase the sambar, which means that there is more protein and less carbs. This is pattern recognition. And one has to be happy, because remember, one has to taste and share and not just eat and share. So the taste is inculcated in the digital technology system. What food, what meal, what combination, how often. So the mapping, all the inputs which go in the first month are able to recognize this so that one can individualize, curate, and this has a high prediction accuracy. This is studied by engineers in California with a high prediction accuracy. So obviously, with the help of this self-learning health signals, happiness signals, causal signals using sensors and devices and blood chemistry and microbiome data, one is able to decipher the state of a human being's metabolism and then make a cause-effect correlation using a coach and a doctor under medical supervision. So obviously, that is what digital twin is all about. And obviously, it is continuous machine learning. So a member is mapped. There are sensors. Which are the sensors attached to a member? Every twin member gets a CGM, a blood pressure, a ketone monitor, a body scale, and a Fitbit. Every twin member has more than 200 inputs of all the chemistries, including the C-peptides, the diabetic and liver profiles, the hemograms, the micronutrient analysis. Every person undergoes a energy, mood, food, activity, and sleep log. And body composition measurement is done. Sleep is deep dived into REM, deep sleep, and cyclical sleep. Symptom biology is checked at and inputted. And then, of course, in nutrition, more than 10,000 food elements with 87 macro, micro, and even gut microbiome has been analyzed, and a database is created. If the person is on insulin and 20 drugs, all of them are put in the medicine database. So there is a twin nutrition database, there's a medicine database, and all this is continuously monitored for consecutive 35 days. And solutions are then provided and actions are provided with the help of the coach to the person. So it is empowering the person to take action so that they can get their glucose under control and they can reverse it, and they should be happy with it. They should not get under stress about it. So obviously, initially, the person or the human being who's attached with so many devices, there is a Fitbit, there is a coach, there are devices which are attached. They have to do 10 actions per day. So this involves a lot of participation from the patient or the person with diabetes. Almost they have to spend 6 minutes per day, and they have to maintain their daily food log. But after 35 days, only 5 actions are required, 4 minutes per day, and partial food logs. And once the system recognizes it after 90 days, and once the person is healthy and happy, you just need to do 2 actions per day with the watch, Apple Watch, as well as the scale, 2 minutes per day, and no food log is required because now the system has understood the biology and the pattern recognition. So these are the RCT results. Average age around 42, A1C at 8.9, starting A1C. Average duration of diabetes around 4 years, BMI around 27, and you can see excellent reversal. And we also have a control group which has not reversed. So you can see the data is very, very clear cut. Most of the drugs are eliminated, excluding metformin. Many people have stayed on metformin. And the 180 data is very, very robust. And all the diabetes metrics, whether it is A1C, whether it is HOMA-IR, whether it is lipid profile, they are all changed. And we have applied both the definitions. When the trials commenced, the remission definition was not in place. But now with the trial on board, you can see the remission definition has been in place. And the A1C improvement is consistent. And the delta average is very robust. And it's independent of BMI. Whether you are low BMI, high BMI, whether you lose weight or you don't lose weight, it is still independent of it. Many of the diabetes reversal programs are closely related only to this. We presented this data last year virtually in the International Congress of Endocrinology, where I presented this data for the correlation of the insulin resistance and glyco-HB with the precision. In fact, Vansi was also an author of this paper, and you can see that the forest plots are very categorical. The A1C change is very robust. Then at the ATTD last year, this year also at ATTD, we had the glycemic variability paper. And again, Dr. Paresh Samanna, myself, Dr. Sabu, we presented this data. And clearly you can see here that the glycemic variability comes down very, very impactfully and effectively. Last year at ADA, virtually, we presented the glycemic and extra glycemic results of the interim results of the trial, and this data was very clear cut. Last year there were very few patients. This year we are presenting 1 year data, and all the p values are consistently significant, whether it's BMI, blood pressure, liver profile, CRP, the atherosclerotic risk index, and so on and so forth. And finally, this was a late breaker poster at the ACE last year. This year on this Friday at San Diego, again I'm presenting a poster on the remission, what causes remission. Again, that's embargoed, so I'm not talking on that, but this is last year's poster. where you can see that digital twin enabled precision nutrition induces remission of diabetes independent of obesity markers. So if you look at the graphs here of body weight deltas, the delta A1C versus delta waist circumference, very, very clearly you can see that the data is very robust and sustainable. So what does this digital body twin do? It fundamentally looks at 174 health and experience signals and creates for every human being a digital twin for each member, and human touch is very important. So it is not just a CGM, blood pressure monitor, ketone monitor, smart scale, Fitbit, Apple Watch, and a twin app. It is beyond that, the happiness level, the energy, the mood, the medicines, the symptoms, apart from organ profiles, biomarkers, endocrinology, and vitamins. So it's all about integrating all this and precisely ensuring that the sensor readings, member logs, blood reports, and are all put through databases using machine learning and artificial intelligence into a nutrition database and medicine database to curate, individually curate a nutrition, medicine, and lifestyle plan, which is cohesively developed by doctors, coaches, and a mobile app. And that's how remission is now a reality. So obviously we can use technology for a real-time, possibility of remission. And these are the 1, 2, 3, 4 criteria for remission. As I told you, A1C less than 6.5 for 3 months without drugs, a persistent low CGM value. A1C must be measured before the intervention and should be followed up every year. Of course, the remission definition has a lot of limitations. So patient-centric care is the main philosophy today. So if you are in digital diabetes care, it's all about patient centricity. And wherever you are in the ecosystem, whether it is in the hospital space or the clinic space, it is all about patient-centric care. And in the digitalization of diabetes, I have to thank Bansi and Maluk because it's all patient and provider burden. We are in a difficult geography in India, and we have access issues, we have affordability issues, but we can do efficient therapy decision making, and we can generate excellent outcomes through digitalization of diabetes. So it's a very, very doable concept. Obviously, I never stop any oration or slide without this slide. Though we are digitalized, digitalization itself can lead to poor health. So digital detox 1 hour every day is also very important. Listening to music, playing your hobby, diverting your mind. I wish all the moms a very warm Mother's Day today. Sleep on time and sleep well. So clearly lifestyle is the key. Eat less, eat on time, eat slowly, eat in the morning. There's a lot of chrononutrition to it. Eat right, walk more, do physical activity, sleep well, sleep on time, but smile. Because happiness is as important as good health. And again, once again, I thank Dr. Bansi Sabu because, it's all about a team management for starting this whole Digital India movement in the space of diabetes and the entire team. And I also thank Maluk and Jahangir and Twin for allowing me to experience what is digital diabetes care in real time. I have seen it in commercial space, I've seen it in randomized controlled trial space, and it is here to stay. And COVID only ensured that we are able to do this more efficiently. I didn't know how to handle a Zoom meeting. I didn't know how to go on internet. I didn't know even how to handle a WhatsApp. But I am reasonably confident and certain now that I am much more techno savvy. And we have a common goal. Our common goal is to ensure that people living with diabetes, can we offer them better outcomes, better care? Can we keep them complication free? And can we keep them in remission lifelong, particularly in the type 2 diabetic space? So thank you once again for the opportunity and the honor. And if there are any compelling questions, I'll be more than happy to answer. Thank you so very much.